tracheostomies, laryngectomies, and TEP, which is tracheoesophageal prosthesis, care and management. Oops, it went.
Yeah, now okay, good.
Okay, yep, now we're good. Alrighty, so this goes into our goals and objectives. We want to describe the purpose and reason tracheostomy, laryngectomy, suctioning is necessary. Describe the precautions and common complications with suctioning. Demonstrate suctioning and what we need to document so everybody will be on the same page. As far as documentation goes, let's see, describe the reasons for tracheostomies and laryngectomies and the difference between them. The need for care for both of those situations. Define the risks that are most common complications regarding T&L care, and demonstrate tracheostomy laryngectomy care, document the outcomes of all that. So we'll start with, I guess pretty much everybody in here has seen trachs, and there's one. If you see, they have the long tube and the little plunger at the end. That's a pilot. That's because that's a cuffed trach. This one is not. You notice it's nothing but plastic. Looks like a dipstick. So usually there's two things we tell you don't want to see in a SNF, but eventually you guys will be ventilator units, so that doesn't really hold true in the long term. Usually, you would not want to see a patient come in with a trach that has a cuff on it, because typically you have no reason for a cuff trach unless you're going to put them on a ventilator. That's the only reason you'll have a cuff trach. Okay, and then the other would be a trach like Bob has in here, which is a twist and lock, where the inner cannula, you twist it, unlock it, and you remove it. These are not disposable. These you have to clean, so don't throw them away. If you have to twist to get that out, don't throw it away. You're going to use your trach cleaning kit, Trach Care kit, and you're going to clean that. Usually when they get a facility gets that type in, they'll call, or well, you guys will have an RT, so you won't have to call. We'll get that changed over to the disposable inner cannula type, so that when you come in to do the Trach Care, you just pull that out and throw it away. And then you're going to have a new one in a pack that you're going to take out and put in there when you get done. The time to do that is, 15 seconds? The time to do that is, depends, 15 minutes. If you don't get called out of the room to go to somebody else's because you're in that room too long. So this is always more convenient, plus it's safer. No chance of cross-contamination, infection, or anything like that, because when you have that inner cannula out, it's a process. You don't do it right, then there's a chance of a complication down the road. So normally there's the three pieces: the trach itself, the inner cannula, and an obturator. The obturator is what we use to insert the trach. The reason being, so if I'm blindly trying to find a hole in the trachea with that, I'm scratching, pinching, I'm not doing a good job, that's for sure. So we're going to use an obturator. Nice, smooth, rounded. And believe it or not, if I've got tissue or something on that has fallen down over the opening in the airway, I can actually feel my way up the airway till I find the hole. I have had several patients in the past that, once you pull this out, you weren't going right straight back in. You actually had to start below it. and work your way up, because you're kind of pushing the tissue out of the way until you get to the hole. Your obturator, they come in different shapes and forms depending on the particular brand of trach. That's an obturator. This is an obturator. So they come all different configurations. If you have a trach patient, the obturator should always be in a baggie or some type of container, either taped to the wall at the head of the bed or in the top drawer of the nightstand, or we have a couple facilities, every room has a cork board in it, so the obturator is going to be in a baggie that what I actually do is, so this is a brand new trach, and so when I open this up, inside there is sterile, and then when I get the trach and everything out of the little bag that it's in inside this, that's what I use to put the obturator back in when I get done. And then that, at these two facilities that have the cork boards, it's always going to be thumbtacked up in the one corner. The big thing is, wherever you put it, make sure you put it in the same place in every room, because you may have put it one place and you come in looking for it and it's not where it was the last time you had to hunt it, and that patient's waiting to go out. You should always send the obturator with the patient. If they're leaving your building, this should go with them to EMS. The downside of that is, you're probably never going to see it again. Okay, but if you have, which you will, a backup trach in every patient's room, there's another obturator in there. Okay, so make sure you send that if they go out, and don't raise sand when it doesn't come back with them. Another thing about trachs is, if you go in, this is a cap actually for the one Bob has in. Okay, his is red. This is for a regular Shiley. Capped. And then this is just kind of a generic cap that will fit most any hub. Okay, so cap. The reason I point that out is, if you go into a patient's room, say Bob, you go in to see Bob and you see that red on there, if you don't know what's going on because he's got red on, don't do anything with him until you go and find out. Either from your RT in-house or probably your ST is going to know. For a patient to eventually become decannulated, part of their criteria is being able to be capped for a certain period of time without needing suctioning. So if you go in and Bob says, suction me, and he's got that red thing on, I'm going to go find my RT or my ST and I'm going to say, why is he capped? Well, he's working to be decannulated and he's like 22 hours into his 24-hour period. You twisted that, took it off to suction him, he just lost his 22 hours of time. And you start the process again. So if the patient's capped and you're going to try to do something for him that would require removing that cap, check first. Okay. Let's see. So any questions on the trachs or the pieces or anything like that? No. So let's see, that is the diagram you have there is the tracheostomy tube on that page in your diagram. And then, do we have the, okay, there we go. So I skipped a couple there. Tracheostomy versus laryngectomy, and what is a laryngectomy and its purpose. So I've skipped a few, but I'm going to go ahead and explain it. So a patient that's had a laryngectomy done, this has been removed, usually cancer, okay, or tumor sometimes will be impaired, so they'll remove all this. When they do that, you'll see on that diagram. Now look at where the airway, under post-laryngectomy, look at where the airway is now. The airway comes out right here. They have surgically gone in and redirected your airway to right there, and that stoma has been surgically created. Okay? This is no longer connected to this, unlike the tracheostomy. The tracheostomy is merely a hole in the airway, but it's all still connected. Okay, so there's a main difference, or a big difference rather. So with the laryngectomy, you have a true full neck breather. I go like that, he can't breathe. Okay. From a RT standpoint, I would rather have 6 laryngectomies than 6 trach patients. Why? That stoma's been surgically created, so whatever they may have, a Stabilibase or Larry tube, whatever, if it comes out, I don't have to go, oh no, how long's it been out? Is it closed up? Am I going to be able to get another one back? It don't matter. If it's the size of your thumb now, it's going to be the size of your thumb 6 weeks down the road with nothing in it, okay? Unlike the trach. If the trach comes out, then you have to worry about, you go in, oh, how long's it been out? Am I going to be able to get a new one back in? Or, this, that, and the other. Okay, so a big difference as far as the stress level goes with the laryngectomy versus the tracheostomy. And there's just a couple of comparisons on that previous slide. So with the laryngectomy patient, like I say, don't be intimidated by the laryngectomy. They're easier to me than doing a trach patient. So this here, if you just take a look at it, pass it around right quick, that's called a Lary tube. So a patient that has a laryngectomy done is they have a couple of options. Some may want to wear the Lary tube, and so as you can see, it's just a kind of a protective device that will go into the stoma. You'll notice the angle of it is about 45 degrees, so it's designed to just seat right against the stoma, and you see the 2 butterfly tabs on the side. You see the 2 butterfly tabs on the sides. It uses the same trach collar as a tracheostomy does. Big difference is, when I say seat, it just seats just like that. No gauze or nothing like that, that you have to put behind it. So say you walk into Bob's room and you see his Lary tube laying on the floor. Just pick it up, rinse it under warm water, dry it off, put it right back in. No big deal. So it doesn't matter if it was out 5 minutes or 5 hours. His stoma didn't change. Okay. So that's a Lary tube. Again, it just seats right there against the stoma, so no gauze or anything, and a regular trach collar. So when I go in to do trach care, Lary care for Bob, all I'm doing is taking this out, clean around the stoma if it needs cleaned, and put it back in. We're done. These things here, feel those, check them out, and pass it around. These are HMEs, heat moisture exchange. So that little bit of what looked like foam in there is a hygroscopic material, which means that it absorbs moisture out of the air, and so when they exhale, any moisture will be trapped in that, so that way when they inhale, they're getting some of that moisture back in. You also noticed, I hope, that you can push on that, and that closes. Okay, this HME just pops right in there, like that. Okay, they actually make 2 different types of these HMEs. One's high flow, one's high humidity. So the theory or the practice should be, while you're awake and active, you're going to use the one that's high flow. When you're in bed asleep at night, you're going to use the one with high moisture. Okay. The bad thing is the patients usually can sense the one, because the one with the high moisture, the flow, there's more resistance to flow, and they can sense it when they're trying to breathe. So they use twice as many high flows versus high humidity. Just because.
Do you change those out?
It depends on the patient, but typically either one is going to be, the patient's going to know, because the foam has become absorbent, and that is causing resistance in their breathing, and they'll know when they, so it just kind of patient dependent. So that's the HMEs for the Larry tube. Now, not all patients with a laryngectomy are going to use the Larry tube. They're going to use, they may opt to use one of these. So this is called a Stabilabase. The back side of it is, you peel it off and it's adhesive. So what you would do is peel off the adhesive, the backing, and these come in about 14 or 15 different configurations, so you can match the patient's anatomy to get a good fit or whatever. And all you're going to do is place that opening over their stoma. So it's going to be just like that, and typically these are good for 24 to 36 hours, kind of depends on the patient. You know, if they've got real oily skin or they sweat a lot, stuff like that, then it's not going to last near as long. But normally 24, 36 hours. And also, how convenient. The HME just pops into this too, so they still have some, protection from the airway. Most of your laryngectomy patients, Atos Medical, and the products are Provox. They keep track, the doctors stay connected with Atos Medical. And so if you were to call and say, we're getting a laryngectomy patient here tomorrow, chances are their rep already knows that, but we would call them and say, hey, we're getting, at Logan, we're getting a laryngectomy patient tomorrow around 2. And the rep will be there, as well as the patient coming through the door. They're real good about working bedside with you if you need a little bit of impromptu education. They may bring some supplies with them to get your, to hold you over till your central supply person can get you some supplies in that you will need on a regular basis. Also, they have a going home package. May make it here with the patient, or it may go to the patient's home, but that package is a real nice leather bag packed with all your goodies, skin barrier, adhesive remover, wipes, in addition to the Stabilabases, HMEs, or if they're wearing a Larry tube, an extra Larry tube, and all that kind of stuff. So that company is real good about helping you out. Now the button is not anything that I've seen, so I'm not that familiar with them. I would assume it is similar to the button a tracheostomy patient can get, which, well, it'd be a little bit different, I'm sorry, because the tracheostomy button actually goes from the airway to the outside of the stoma, has a little fitting so it kind of stays locked in, and it's like not permanently capped off, but it's not a cap that you would be removing here, okay? And it provides permanent access to a stoma if that patient were to have to go back. Now, over the years, I probably have seen about a half a dozen of the trach plug. And the Larry button, like I say, is it's the shape of the stoma, and it will determine if you will use a Larry, can use a Larry button. It should fit comfortably without causing any irritation. So it looks kind of like a Larry tube, but a short version, and it's going to pop into the stoma. We already went over the Stability basis. There's a different configuration from the ones that I just showed you. There's about 13 or 14 different ones there. Now, this is the TEP. So we never used to deal with laryngectomy patients till about 4 years or so ago, and I guess they were running a special on them in Charlotte. And all of a sudden I was getting calls from our facilities up there, and we're getting a laryngectomy patient. And so it was like, wow, we got to learn fast. So that was when we incorporated. And in a period of 4 months, we had 6 laryngectomies go into facilities that we had in the area. And of those 6, only 3 opted to have a TEP. The other 3 did not. And so what I found with those 6 patients, the ones that were less cognitive or needed more care from the family members did not have the TEP. The ones that were kind of walkie-talkie, do-it-myself, they're the ones that had the TEPs. Okay, because it does require a certain amount of care. Let's see, Tracheostomy Care, Laryngectomy Care. I'm kind of skipping around here a little bit. All right. So, when you have to do TEP care, it's simple. If they have a TEP, you're going to get 2 pieces of equipment, I guess you would call it. You're going to get a brush that you're going to get a brush that's going to look a little bit like this. The only difference is the diameter of the bristles are only going to be the same diameter as the TEP. Okay, so they're not going to be this. The opening in the TEP is about 1/8 of an inch, maybe 3/16 of an inch. And then the bristles are only going to go as far as the TEP is deep. So you may only have that much in bristles. Okay, and then at the end of the bristles is going to be a plastic collar molded onto your brush, so that way you can't go in too far. Again, this is designed for the TEP that patient has in it. Okay, and the other little piece of equipment you're going to get is going to be a plunger. It's about 6 inches long, 5-6 inches long. Plunger at one end. And then at the other end looks like a miniature Christmas tree with a hole in it. And what that is designed for is so you can put the Christmas tree at the end of the TEP and plunge some water. You're going to put some sterile water in there and you'll plunge it through. So those are the 2 things you'll have. So the first thing I'm going to do, and you'll actually have to look in the stoma, because like standing right here like this, if I had one, you probably couldn't see it. You're going to have to look up in there, okay? Kind of, at an angle. You're going to take your brush, sterile water, you're going to insert your brush, and then gently you're going to back and forth a little bit and twist it at the same time. And you're going to do that about 3 or 4 times, okay? Don't get crazy or aggressive or nothing. Just back and forth a little bit, twist 3 or 4 times, remove, clean it. Now I'm going to take my plunger. I have put some sterile water in it, and I'm going to take that little Christmas tree and I'm going to put the Christmas tree right at the end of the TEP. Put it up, and then we'll squirt some water. When I squirt some water, I'm going to get one of 2 reactions. One is either going to be, which is good, because that means it went down the other side and it triggered a tickle or whatever you want to call it. Or you see water dripping on your end. You see water dripping on your end means it's not patent. It's still clogged up. So you're going to go through the same process again. You're going to clean in, back and forth a little bit, twist 4 or 5 times, out. Same process with the plunger, and it's still water on your side. You're going to let the doctor, nurse practitioner, whatever know that his TEP is not patent. You guys aren't going to pull it out. Sometimes your patients can patients can remove these if they go home with them and take care of it. And chances are your doctors here aren't. Your pulmonologist might now. I take that back. Most of your GPs and NPs and all that, they ain't touching it. Okay, so they'll probably send them out. And so that's how you know your TEP is patent. Tracheostomy Care. I'm going to go ahead and get into this with Bob. So it's kind of a simple process, and if any of you folks have already done this, I'm not really trying to change the way that you do it. We just want to make sure that everything is done completely and correctly. So starting from scratch for Trach Care, you need to make sure the order sets are in your chart for Trach Care per protocol, what have you. A big thing to remember on your orders is so if Bob's been here for a year and you were on vacation for a week and you come back and they say, oh, guess what, Bob was sent out to the hospital last week while you were gone. When you send a trach patient out, or probably any patient, I'm just familiar with trach patients, and they come back, you lose some of the order sets. It's inevitable. They don't all get brought right back in. And inevitably, they won't all get picked back up. So especially if you know your trach patient's gone out, make sure the order sets are back in the chart for your trach care, your suctioning, all that kind of stuff. Okay, so we've made sure that our order sets are in place. I'm going to get my supplies together, whatever I need. Typically, you're only going to need about 4 items. Q-tip swabs, your sterile water, your split sponge, and if I'm going to change his collar, I would need a new collar, and an intracannula. Disposable, preferably. Most places go with the disposable. So I've got all that stuff, and I've come on into Bob's room, and while I'm talking to him and getting everything together, I've already donned my PPEs and all that. Bob might not remember me from Adam's house cat, so I'm going to remind him who I am, why I'm here, this, that, and the other. And I'm getting everything set up. So the first thing I'm going to do is Bob's on oxygen. I'm going to go ahead and take this off because he's not going to be, I just do that for display. He's not going to be on a BiPAP. So Bob's laying there. One, he's a trach, so they should never go below 35 degrees. Okay, make sure they stay up. He's got a trach mask on, and he's getting oxygen. So I'm going to make sure that I put a pulse ox on his finger, and so that way I can monitor him while I'm doing all this to him. I've got all my stuff set up, and I've checked my patient identifiers, whatever you guys have. Some have the pictures in the MAR and clipboards hanging at the bed, and it just depends. Picture on the door entrance and the name. So just make sure you do that, because Bob's been here for a year, and so I know every time you folks are not checking the patient identifiers, and that one time you don't is when State's going to be right behind your back then. What didn't you just do? And I tell you this because I've seen it happen. And it's hard not to do that. I understand. I mean, I get it. Make sure you do all the proper stuff. If you do it all the time, you don't have to worry about, oh, God, am I not doing it because State's here? Just do it all the time. Okay? We've got everything. We've gone through all the formalities of what we need to go through. So I'm going to get ready to do my trach care. He's already got his pulse ox on. And so the first thing I'm going to do is he's on oxygen. So I'm just going to move my trach collar to where I can, I don't have one up. my trach collar down to where if I need to put it back up on him, I can just go like that. I'm not going to take it off and set it over here, okay? So I have it where I have access to. Some of these trach cleaning kits, trach care kits have the cloth or drape, whatever you call it, that you can put across them. I typically don't, but some do. You can place that across them. The first thing I'm going to do is remove the inner cannula. And the reason I do that is because you don't know what's on the other end of it. And if it's nasty, gooey, stringy, whatever, green, I want it to get on the dirty cloth that I'm getting ready to throw away. Okay, I'm going to pretend this is a throwaway, even though it's not. This is not a throwaway. I'm just going to look. Reason being, if I see brown, typically it's going to be brown or tan, crusty flakes, first thing I'm going to do is look at my water bottle, because they're not getting humidity. I mean, no other explanation. If you've got dried crusty flakes in here, it's because the water bottle's empty. Okay, so that's one thing I'm going to look at. The other thing is looking at color primarily, if there's anything strange as far as the color goes. So I throw it away. The next thing I'm going to do is remove his gauze. And usually it's just a gentle tug out from under there. And I'm going to pay attention to what's built up around here. If it's just white or tannish or something like that, no big deal. But if I'm seeing dark brown or red, I mean, it could be fresh blood, then I'm cognitive of that. So when I get to doing my trach care closer, cleaning the stoma and everything, I'm paying attention to what I'm seeing. Yes. No. One, you're giving him oxygen. He's sat 98. What am I going to do for 2 minutes? Give him more? He's already at 98, right? Okay. For this process, your question would be more applicable to if I was getting ready to suction him.
Okay.
Then, yes.
Okay.
Does that make sense? Mm-hmm. Right now, it doesn't matter. If he drops, I'm going to slip the mask up wherever I am in the process. If I see 90, he started at 98 and now I see 88, it's going back up on there until whenever he comes back up. The next process is going to be, I do mine, I split the stoma into quarters, so I have 4 pieces of the pie, and I'll use 4 Q-tip swabs. And I'll go, when I say secure the flange or secure the trach, it's not that. If you do that, you're just pushing the trach into his throat a little bit more. And if there's not much clearance there, you're pushing the trach against the back of his airway, and I guarantee you 100 to 1, he's going to start coughing all over you until you let go. And then he gets back to norm. Okay, so when I say secure the trach or secure the flange, grab it like that. You've got one right there you can practice on. But I'm going to grab the flange and hold it. That keeps it from doing anything while I'm maneuvering around, okay? Does that make sense? No, it just drives me crazy when folks do that. So I've gotten the gauze out, and now I'm going to clean around the stoma. Like I said, I use 4 Q-tip swabs. I've moistened them with sterile water, and I'm going to secure the flange. And then I'm going to start with the one corner of the pie, and you always move away from the stoma with your Q-tip swab. Contact away, because you don't want anything migrating back into the airway through the stoma. Okay, so I'm going to do that 4 times, all 4 corners, and throw it away. Sometimes there's a lot of buildup up under there, and you may actually have to take a 4x4, fold it in half, moisten it, and then just slide it up under the flange and seesaw it back and forth to try to get it clean. And I've had to do that four directions with a new cloth each way. Sometimes they can get rather nasty. But that's one way that you can clean. The other, while you're cleaning, you want to make sure you clean off the flange, the front of it. I'm sure on that one that was passed around, you see all kinds of numbers and letters and stuff on there. Those are all significant, okay? If they weren't, they wouldn't be on there. And the time you let this go without being cleaned for a week or whatever, and everything is crusty and built up, is going to be the day the doctor calls you, 10 o'clock at night, and he's going to say, what kind and size trach does Miss Jane Doe have in? You run in there, oh, guess what? Nobody's cleaned that in a week. So you're tying up your time and the doctor's time, trying to get all this crust scraped off of there so you can see what the numbers and the size are. Again, all this stuff I'm sharing with you has happened. I mean, this is all from experience, so I don't know why he wanted to know at 10 o'clock at night, what size Miss Jane Doe had. I don't have a clue, but he did. So we've got everything cleaned up real good, and so we're going to say an hour or so ago they bathed Bob, so his collar is soaking wet. So I need to change the collar. Dang. Well, I didn't set out as many toys as I thought I had. So anyway, I'm going to take the new collar, just like this. I'm going to open it up and I'm going to slide it underneath Bob. Okay? So I've got it ready to go up. So what's going to happen is when I secure the flange, I undo this side of Bob's collar. Good Velcro. And I lay that edge down. I'm still here on this side. I'm going to grab the new collar, run it up here, feed it through or attempt to feed it through here. And we're going to hook it. And now I'm going to go to the other side and do the exact same thing. I'm going to release the old one, lay it down. I'm going to grab the new one, come back up, reinsert on this side. My fingers ain't wanting to work right today. Feed it through and attach. Now the big thing to remember is when you're doing that, if you're not comfortable doing that by yourself, get a coworker to come in and just hold the flange for you. Because once you let that collar disconnected, remember this is just like a dipstick. If it's not connected and you're not holding it and that person goes, it just flew out. Okay? So if you're not comfortable doing that, then because it's only going to take, even me doing it by myself took me, 2 minutes? With a helper, it might take you 1. So get you some help rather than taking a chance of that working its way out while you're distracted or what have you. All right, so I've got his new collar on. The big thing with collars is, now these are a little bit challenging in that they've got all that elastic. Okay, so you've got a little bit more give than like the Posey brand or those that don't have any elastic. So you always want to have 2 fingers between the neck and the collar where you can move it. Okay, like I say, with the ones with elastic, it's a little bit more challenging, but you don't want any more than that, because if you do, this can work out and get into a pocket. It doesn't necessarily have to come all the way out. It can just come out of the airway and lodge over to the side there, and then they wouldn't be getting their oxygen. If they're on oxygen, they may have difficulty breathing. They may not have difficulty breathing. I got a call from a facility one time where the trach had come out during the night, nurse so-and-so put it back in, but we can't get it sat up. So I went over there, and so what happened was what I just said. They had put it into a pocket, not into the airway. As soon as I was able to get it back into the airway, his oxygen level went right straight up. Okay. So let's see. One thing you may have with, for some reason, little old ladies. It's too tight, I can't breathe, it's too tight, and they start whining and crying and just carrying on. So, this works, this really does work. So I said, okay, Bob. Bob's just like a little old lady too. He starts whining and crying about that collar's too tight. So what I do is say, Bob, okay, I'll take care of it in a minute. Let me get because I'm just about done here now. Let me get all done and we'll take care of that for you. He says, okay. So I go ahead and put the new split sponge in. And I'm trying hard to do this where everybody can see. We're just going to lift one side of the collar up a little bit and slide that up under there. And then slide it over to where it's positioned where it needs to be. And I'm going to do the same thing on the other side. Just lift up, slide it under there, and then position it properly to where it looks like that. And I'll put the new new Intracranial. Oh, that's right. We didn't. Okay. Let's see. So I will put the gauze in before I put the new Intracranial in. The Intracranial is going to be the last thing I put back in. The reason you have a patient that's constricted or whatever, they're limiting your access down there. And anything else, even the hub of this, that's in your way is going to make that even more challenging to get the gauze in place. So I will do the gauze, and the Intracranial will be the last thing that I'll put in. He's done, and I'll put his mask back on, trach mask back up, and we'll make sure he's comfortable and everything. And he reminds me, my collar's tight, my collar's tight. So I get all my stuff picked up, cleaned up, garbage thrown away, what have you. And so what I'm going to do to help him, I'm going to tell him, I'm going to fix this for you, Bob. So what I'm going to do is grab the collar on each side, and I'm going to pull it forward, okay? And all I'm doing is stretching this back here a little bit, but it releases some of the tension on the front. And he goes, oh, that feels better. And I'm out the door. I really didn't do anything, and about an hour or two later, he's going to be complaining again, and I'll have to go back and do something else. But that got me out of the room then, and he thought I fixed it, okay? And some of these people are special. And so you need to learn a few of these tricks that will either buy you time or buy you an escape. There you go. Any questions about Trach Care or any of that kind of stuff? I would assume probably, Mary, you guys will go to the disposables as well on a regular basis. So like I said at the beginning, if you see a twist and lock, make sure you let your supervisors or whoever know, so we can make sure that we get that changed. Okay, let's see. Next, laryngectomy and TEP care. It's going to be very similar, only not quite as much. Like I explained with the TEP. With the Larry tube, if they're just wearing a Larry tube like this, there's not going to be any gauze or anything there. So all you're really going to do is let the collar, if you need to replace the collar, you can take it totally off, or just release the collar and pull that out. Warm water, clean gauze. You've cleaned it, it's ready to go back in, and then clean around the stoma with sterile water. Don't use any peroxide, and definitely no aerosols or sprays. Okay? And you're going to reinsert and put the collar back on, and he's done. with the Larry tube. We went over the TEP, and then the only other, if they opt to have the Stabilibases, like I say, 24, 36 hours. Usually, if you see it start breaking away from the skin nearest the plastic insert part, once that starts happening, you might as well go ahead and change it. And so what you'll do is just carefully remove that. Use your adhesive remover and make sure you got that all cleaned up and everything. Give it adequate time to dry around that area, and then you're going to reapply a new Stabilibase. And that's that.
Do they ever use stitches on these?
On which?
The trachs.
Trachs. When a trach has been initially placed, it's going to have anywhere from 4 to 8 sutures. It depends on what kind of a job the physician did that placed it. I've seen butcher jobs and have had to remove as many sutures from the stoma as I have had from the trach. But normally we're going to say there's going to be 0 to none, or 0 to 2 sutures to the stoma area. Okay, and then the other sutures are going to be usually at the 4 corners. Okay, and so if you guys are ever the ones to remove the sutures, bear in mind, typically top and bottom are also connected. Okay, so it's not going to be one and out, because if you go one and out, you're pulling that one too because it's connected. Okay, so your 2 sides, top and bottom, typically are going to be connected from top to bottom. So that's going to give you your 4 sutures. And after, those will come out the initial change. It will vary from 7 to 10 days. Pretty much 21 was the max. We would never leave them in that long. But usually 7 to 10 days is going to be the initial change. I don't know what the rules will be here. Usually the initial change has already been performed before they are sent out to a SNF. That's not always the rule. A couple weeks ago I just had to go do an initial change in a skilled nursing facility. Unusual, but it does happen. The reason they usually want the initial change done in the hospital is it still has the cuff on it. So that means the stoma and all that has tried to close around the tube. Well, that one's inflated, but there's one, even with this cuff deflated all the way, look at all that extra that's there. So, and remember now, the stoma has grown to the tube. So that means when I pull out, I'm pulling all this stuff too. And like I said, I've seen them get very nasty. That's why they usually do them in the hospital, not here. And then from that point after, it's just a case of this, and you're going to change your trachs every 29 days. So this is an interesting point, because some physicians say 3 months or whatever. Page 5, when you open the box of any trach, there's going to be a book in there for that particular trach, okay, brand. So in this particular one, on your Shileys, it's going to be on page 5. The suggested time is 29 days. So we typically will go from 28 to 31 days. We try to stay. And that's how frequently. So if you have a doctor that writes an order for 3 months, you do it however you diplomatically are going to point this out to him. It's 29 days. If he says, I don't care, whatever, that's fine. He's the doctor. You just document, physician was shown the manufacturer's recommendation of 29 days. So that way, 3 months down the road, that thing comes out looking like a smoker's been on it. They do. I'm telling you, they do. It will look nasty. And the family member sees it, and they start jumping on you. So I don't point that out to get anybody in trouble or to have an attitude, but protect yourself. That's what the book says. You don't want to do it that way, that's fine, but you do. Let's see. I know I'm kind of skipping around on these things. Mike doesn't do that. He does slide 1, 2, 3, 4, 5. If you see anything in here that you think maybe I've missed, or you would like me to discuss a little more in depth. Yeah, I'm stuck again, Mike. Supplies and equipment. So for the Trach Care, you're probably going to use these kits, although most of the stuff in there you won't need. The new Intracranial, split sponge, Q-tip swabs, collar if you're going to change the collar if it needs to be changed. Gauze pads also. Let's see. The suction machine, we'll cover that right now. Trach kits, we need to fix that one. No hydrogen peroxide. The hydrogen peroxide and sterile water. So the important thing about those two items is hydrogen peroxide, you're only going to use in that tray with that kit if you have an inner cannula like Bob has here that has to be cleaned. Okay, you're not going to use any peroxide around the stoma or to clean the patient or anything like that. Okay, you're just going to use sterile water for that purpose. If you do end up with a trach like this that you have to clean the inner cannula, what I suggest is you go to YouTube and you put cleaning trach or cleaning tracheostomy, and there's about 14 or 15 different pretty good videos on that. And the reason I suggest doing that is because almost all of them uses a different kit. So your particular kit, you might have to remember to carry your little bottle of sterile water in there, or you may not. Your kit may have the little pack and you're good to go. So that's the only reason that I recommend the YouTube videos. Your cotton tip applicators, again, if you use the Trach Care kit, it's only going to have 2 in it. So you should know ahead of time that, if you're going to use the 4 Q-tip method, you need to bring another 2-pack of Q-tip swabs. You've got your 4x4 drain sponges. Again, those are either going to be individually wrapped, which you use everywhere, or there's going to be one in the Trach Care kit. One thing to remember on your split sponge, don't take a 4x4 and cut it. Okay, don't do that. That's a no-no. Find a drain sponge somewhere that's made that way. And the reason I say that, some of the older kits have that gauzy stuff, and it's going to fray, and you don't want that fraying down into the stoma. There you go, pre-cut for trach. Velcro ties, we kind of went over them. You have these, I don't know what kind you folks will have, but these with the elastic, or posy, and there's another type out there. They do not have the elastic. Same principle, you adjust it when you put it on. Disposable inner cannulas, we've gone over that. Spare trach, usually in the LTAC anyway, we would have the same size and a size smaller. Some facilities just do the same size, some do the size smaller. So it'll be up to your facility but there should always be a spare trach in that patient's room. Clean and sterile gloves, and for the cool aerosol setup, which we already went over that. So this is your cool aerosol setup, from the compressor, nip cap, line, drain bag, bleed in, your O2 bleed in fitting, to your trach mask and your concentrator. Okay. 3 foot, okay, that's for the aerosol setup. Alrighty. Now for suctioning, comes into where you were asking about pre-oxygenate. That's a pretty good habit to get into, especially if you're not familiar with your patient. But normally, once you become familiar with your patient, you'll know, is he one that I need to pre-oxygenate, or is he one that usually does fine? Bob usually does fine. I don't give him any extra gas. He just lays there. But sometimes you're absolutely right, you do. You want to give them. So if they're on 2 liters, you're going to crank it up 2 liters to 4, and probably let it run for a minute or 2.
I put my windows down.
Oh, you might want to go put them up. Yeah. Anybody else got their windows down? So now we're going to get ready for suctioning. Back to the order sets. Suctioning should always be written PRN. Okay, some doctors are going to write you the order for suction Q2. Okay, I get it. I'll explain it to you why they do that. So, doctor comes in to see Bob once a week. He's in there for 2 minutes. Every time he's in there, Bob's hacking and gagging and choking and all that stuff. So doctor says, they're not suctioning my man. I'll take care of that. I'm going to write the order for suction Q2. So now the doctor's thinking he'll be taken care of now. There's no reason to stick a tube down an airway unless it's needed. You know, are you going to walk up to somebody and stick a needle in them with nothing in it just because you feel like they need a needle? Okay, so that's the order. If you go in there and you listen to Bob and he coughs, he's clear as a bell, you stethoscope him, clear as a bell, he doesn't need suctioning. Just make sure you document. Lung sounds clear, no suction required at this time. That lets them know you were not oblivious to the order. Doctor may or may not like it, I don't know, once he looks through the chart and no suction, no suction, no suction, no suction, no suction. And he walks in there and Buddy Bob's hacking and gagging and everything else again. So it's a vicious cycle. But suctioning should always be PRN and as needed, and that's up to you to decide. I do encourage you to pay attention to your trach patients because you're their patient advocate, basically. So and he might not be in the state to tell you. Some do that to let you know, but he might not be able to. So if they need suctioning, definitely do. Okay, so when we suction, let's see. Did they say they use single and then
They use single right now.
They use single right now, and maybe probably will go to the cath and sleeve. So I'll go over both of them right quick. So this single-use catheter, which you all should already be familiar with, comes different little kits. It may be one like this, or there's some more extravagant ones. The big thing to remember with the single-use catheters is that it's a sterile process. Okay, so when you first open your pack, this particular pack only has sterile gloves and a catheter. So that means you're going to need a container of sterile water, probably a little box to put you some water in, okay? And again, the process for this, you open your pack, the first thing you're going to take out is going to be your gloves. Now when you're doing that, be careful not to touch the catheter. Everything in here right now is sterile. Okay, so we're going to take this out. We're going to open it up, spread it out there. I've already got everything set up. So our suction device while I'm explaining to Bob what I'm getting ready to do and everything, I'm going to nonchalantly make sure my compressor's turned on. The last thing I want to do is get the catheter all the way down in there. Oh gosh, I forgot to turn it on. And I've seen that happen. So we're going to make sure that the compressor is on, it's running. The next thing I'm going to do, visually, I'll look over and make sure my two tubes are hooked up. One for the suction, the actual suction, and then this one here for the tube that we're going to use on the patient. And so what I will do is go like that and just make sure I've got some suction. If you've never had one of these lids on all the way and you've done that, when that snaps on there, sounds like a tractor trailer tire just blew off. I mean, it will scare you if you've not heard it, I promise you. So everything there is working, so we're going to be all set to go here in just a second. Usually these are closer together in the bed. I'm not walking halfway across the room. But anyway, so I've opened my pack and the catheter is still in there. I opened up my sterile gloves. I've already placed my pulse ox and everything on him. I've pre-oxygenated for about 3 minutes. He's up to 99. That's max for Bob. And the next thing I'm going to do is go ahead and put my sterile gloves on. Okay, so right now I have sterile gloves. I ripped that lid off. Is there any? Okay, I've got my sterile gloves on, and I'm going to get the catheter out. Okay, now right now I can do anything I want to do with this catheter. It's sterile and so am I. Okay, at this point I need to figure out which hand am I going to use to insert the catheter, because that's the hand that I want to continue to stay sterile. Okay, so I'm probably going to use my right hand, and so what I'm going to do is just kind of twist this around and get it to where I can make the connection to my tubing. Okay, so this is, my hand is going to stay sterile because it's the one I'm going to use to insert. So what I'll do is hook up. This hand's dirty now. I just picked up the tubing. Okay, so this is my dirty hand. And I make the connection. My right hand is the only thing that can touch that tube now. Okay? So because our cord is not 25 feet long, I'm hooked up. This hand's sterile. When I insert the catheter into the trach, I am not suctioning. You're not suctioning when you insert in. So what I'm going to do is insert in, no suction, until I meet resistance. I meet resistance, I'm going to back it out about 1/4 of an inch, and then I'm going to start suctioning. And I've seen folks do this, and you know, they're just all over the place. That's fine. At the point you start suctioning to the point you exit the airway should never exceed 15 seconds. Okay? Because literally you are sucking their breath away right now. Okay. So I've gone down and gotten secretions. I flushed my line. Cough for me, Bob. He coughs and he's still got some more. So I'm going to do the same thing. I'm going to insert, meet resistance, back it up about 1/4 of an inch, suction, and then come on out. No more than 15 seconds. Okay, this time I didn't get a whole lot. Okay, so I clear my line. There's 4 elements in suctioning that everybody needs to stay on the same page with and document the same way. So if there's any trending going on, we're able to see it from documentation. So one of those is going to be amount. If I go down once and I get secretions and then he's clear after that, that's a small amount. 2 is medium. 3 or more is large. Okay, so that's how you document your amount. The next thing is going to be consistency. Was it stringy? Was it pasty? Was it sticky? You know, any adjective that you want to use is going to be accurate if that's what it is. Okay. The number 3 is going to be the color. Was it white? Was it clear? Was it frothy pink? Was it green? The reason you want to be consistent with that is, Kathy, is that right? You have the patient for 5 days in a row. Monday he was clear. Tuesday he was a little bit yellowish. Wednesday he was yellow. I maybe would have said something Wednesday, but Thursday is like almost brown. That's red flag. We're going in the wrong direction. Need to let the doctor or somebody know. So that's why everybody needs to be on the same page as far as what you're documenting. Yes?
Just a quick question. So, this is what I'm confused at. Now I'm thinking of wounds. I know in school they say use the COACH acronym, like the color, odor, consistency, and all that. Did you use that with this too, or?
What is it?
Like it's called COACH, like for color,
Color.
odor, amount, COAC, consistency, and something else I forget.
That's, yeah, three of the 5, yeah. 4 of the 5, rather, I'm sorry, yeah.
I ain't going crazy.
Color,
No.
color, we just talked about. Amount, how many times you go down. Consistency, and odor.
Okay.
So, yeah, I just
I don't
hadn't,
get it confused.
yeah, I had never thought about a 4 letters. I'm sure there's something. And the other thing is going to be odor. I know everybody has smelled the rotten eggs. So as soon as you sense that, let the doctors know. So they can go ahead and do a swab and get some antibiotics on board. I'm all done. I've got all my stuff that I'm going to document. Make sure Bob's back up to comfortable. I didn't have to lower him down to do that. It's just I don't have he's going to be at the 35 degrees. When I get all done, I'm going to double glove this. So 1, 2, and then I'll discard. Everybody cool on the documentation and everything for suctioning?
I have a question.
Yes.
I have not used these machines before. Are they just like one setting?
No, actually, that's a good question. So it doesn't really do a very adequate job, but it does. You should set it between 15 and 20. Sometimes, and you didn't hear this from me, you may have to turn it up just a little bit, you know. I mean, but 15 or 20 is usually the max on these units. And usually they're already going to be preset to that. Now remember on the single-use catheter, which is what we just used, you're going to throw it away. Don't stick it in that little pack and put it back in the drawer. So when somebody else comes, that just drives me crazy. You come in there, if the pack's been opened, it's been used, and it's still, how long has it been left? I don't know. No, it's crazy. But anyway, so they may switch over to a cath and sleeve. I don't know if you folks are familiar with these or not. So this is not a sterile process, okay? This catheter is good for 24 hours. So usually what happens is like your first shift person who comes in and does the Trach Care and everything where they change the inner cannula and everything, they'll see this and it'll be like laying next to the suction device where it may be in the top drawer. If the pack is open, I'm going to throw it away and I'm going to put a new one there. That new one is good until I come in tomorrow morning. If it's opened, I'll throw it away. If it's not been opened, it's good for another 24 hours, okay? Because I'm the one that always changes it out. So again, it's not a sterile process, so it'll already be hooked up to my machine. It'll be folded up in the sleeve and in this pack sitting in the patient's drawer or whatever. When I get ready to suction, same process. No suction on. I'm going to feed my catheter out of my sleeve and I'm going to insert. No suction. Same process. I meet till I meet resistance. I did. Back it up. Now I'm suction, and I come on out. There you go. Thank you. And I come out. And it's the same process, and I'm only going to do it the one time. I flush with some water, and I'm ready to put it back in my pack. I'm done. Okay? Any questions about that?
So we see this more or the sterile process more?
It all depends on your facility, but I think eventually they will lean towards these. Financially, it makes sense. If I suction Bob 4 times in the day, I've already paid for 2 of these. If I'm doing the single use correctly and throwing it away each time, where I've had to open 4 of these in a 24-hour period, I've paid for 2 of these. So, yeah, I forget, 51 cents or something like that. And so in a box of 100 of these, same price, I get a box of 50 of these. But these are good for 24 hours. So Bob uses 4 or 5 of these. I could have just bought 1. So I think probably you will eventually lean towards these. And then also with the ballards for your ventilated patients, those are self-contained anyway. Let's see, supplies, we've gone over all of that. No, this is the fun part. Do what?
No, it's not.
No, it's not. All righty. 1, you're going to give the same breaths as you would in normal CPR. It's the difference is how you're going to use this little device in doing it. So it's going to be hooked up to your oxygen just like the other. So the first example is we're going to do Bob, who has a cuffless trach, okay, just like he does right here. And I'm going to go ahead real fast, like I remove the gauze, and I can do one of 2 things. I can either use the mask, which is probably preferred in his case. Why? Because if I hook directly to here, I close the nose and close his jaw, and I give him a breath, I still have area around that trach and stoma, so he's not getting all of it. So what I'm going to do is use the mask, and you use the mask and you try to get as good a seal as possible in whatever direction you have to use. Usually the pediatric mask works better, but you're not going to have one here for sure. Okay, so you're just going to make the best seal that you can. Again, close the nose and the mouth and give him his breath. If you don't do that, it's going right out his mouth. Okay? Okay. The other part is if he had a cuff trach in. If he has a cuff trach in, you're going to make sure the cuff is inflated, and you do that by feeling the pilot. If the pilot's inflated, his cuff's inflated. Okay? It's in there. I'm going to connect directly to the hub, and I'm going to give him his breath. Why? Because this is going directly into his lungs. It can't go anywhere else. I don't have to worry about closing the nose and the mouth. Okay? Is all that?
Because of the cuff, right?
Because of the cuff, correct.
Okay.
All this air that's going in is going straight to his lungs.
Okay.
Does all that make sense? Okay. Let's see. I was going to say there's something else. Yeah, the laryngectomy patient. So you really need to know, if it's a laryngectomy patient, normally you're going to have a sign on their wall at the head of the bed. It's going to say neck breather. Okay, so you want to be aware, if you have to work with a trach patient or a laryngectomy patient, you need to know this ahead of time. You know, if he needs it, you know, am I going to have to make sure I run in there with a syringe so I can inflate his cuff? Okay, so if I have a laryngectomy patient, Remember, if I go like that, he can't breathe. None of this up here matters anymore. I'm concerned with that right there. I'm going to use the mask, make the seal over the stoma, and give him his breath. Okay? All that makes sense? Did everybody already know all that?
Nope.
I know a lot of folks. I know. So we just started doing that. Any questions about any of that? Emergency breathing for a neck breather or partial neck breather?
So this is just for funsies, but, so if it was a family member and you didn't have an ambu bag, you would put your mouth
Yes, you can.
on it?
Yes. Yes, ma'am. The old-fashioned way?
If you were at home and you didn't have an ambu bag.
Yeah, if you did, yeah.
Yeah.
Yeah, I mean, or, you know, a lot of folks carry those little makeshift masks in the little tiny 2x2 bag. Hey, if it works, it works. You may want to start carrying one of them just in case.
Like a barrier.
Yeah.
Right, what if they call?
I find Trach Care satisfying.
Oh, you really don't want to go there.
One of those.
Yeah. That's a journey you don't want to make.
Either like you're like
But I'm here to tell you, I have seen trach patients just start coughing and pow!
yes, that's what I'm saying.
Oh my God!
And it wouldn't, and it don't stop.
Yeah, and then you go, well, why can't you cough like that when I ask you to? You know?
Yeah.
Bam! Let's see. Any questions about anything there? We're good? The oxygen, again, so for this, you're going to have that hooked up to your tank, okay? Not the concentrator. I mean, concentrator will do, push come to shove, but you would prefer to have that hooked up to a tank where you can open up the flow, okay? Let's see, we did all that. Rescue breathing for neck breathers and partial neck breathers. Like I say, make sure you're aware of your situations for those particular patients. You know, it's not like you're going to have them in every wing, a dozen. We're probably only talking about 2 or 3 maybe, you know, at a time. So make sure you're well aware of what's applicable for those patients in case you got to run in there in an emergency situation. Speak of the mouth. that was the diagram you were asking about. All right, yeah. Everybody got a visual on that one? Yeah.
Too much of one.
I hear you. All right. Rescue breathing, we've gone over all of that. Suctioning precautions. We've kind of went over all of that. When you're suctioning, you know, you don't, the 15-second rule, you're not going to do it if it's not necessary, just because an order is something. If the patient doesn't need it, don't be sticking that tube down their airway. So one thing I did not cover that has happened occasionally over the years to me, some respiratory patients will have what we call floppy airways. And so you stick the catheter down in there, and usually when you get to the carina or your resistance, most of the times they'll start coughing a little bit. Well, sometimes they will, and if they have floppy airways, it will literally grab your catheter. And you'll be like, it's not coming. Don't pull on it, just stop everything you're doing. No suction, just let the tube sit there, because in a minute or so, he's going to stop coughing, and you're going to go, got it. and that does happen, that will happen, so don't panic when they start coughing and the catheter won't move, okay? Just
Easier said than done.
I know, instant reflex is to pull that booger out. No, don't do that.
Calm the butt down.
Yep. Let's see. Again, the 15 seconds. Cardiac arrhythmias because of the stimulation, but you're watching them with the pulse ox anyway, so you keep an eye on that. Bronchospasms, what I was just telling you about, that grab the catheter. Atelectasis, back to the grapes. If there's no air getting in there to keep them inflated, they're going to look like raisins. That's atelectasis. Okay. Increased intracranial pressure, I'm assuming is a result of what? Because of the suction and the spasms? Yeah. Lack of non-sterile technique. Again, make sure if you're using the single-use catheter, if you're going in there and you're going to suction Bob and that catheter's already been opened, please don't put it back in Bob. Get a new one, okay? Or anybody. Our other new guy is Darryl. Darryl's down in Florida right now. He's got the job, don't he? Let's see, suctioning procedures, we've already gone through all of that. Standard Trach Care precautions, we've covered all of that. Laryngectomy and TEP care, we've covered all of that. If you guys looking through this have any questions, stop me and I'll definitely cover those for you. And there's some more of the TEP care and the laryngectomy.